Directions. Dr. Jeffrey Chapman, are you there? We can get started, please.
Hi, everyone. Chapman here, and I'm going to give you a little bit of an update in interstitial lung disease treatment and diagnosis, and specifically focusing on idiopathic pulmonary fibrosis. So when I think of someone comes to me with interstitial lung disease or that they have IPF, the first thing I do is make sure that we have the correct diagnosis. Fancy movies where you see the heads-up display that comes in front of the protagonist's eyes, and it shows him where all the good and the bad. Whenever I see someone with interstitial lung disease, this always comes up in front of my eyes, because this is what you need to think of when someone has interstitial lung disease, what you need to think of to arrive at a correct diagnosis. And I usually go from left to right. Most of the time I end up in the right column, but you don't want to jump there inappropriately. Interstitial lung disease, I always ask them about occupational exposures, asbestos, silica, coal mining, not so much, organic sensitivity pneumonitis. I then ask them if there's any reason that doctors could have caused the interstitial lung disease, if they had radiation, chemotherapy, especially these days with the immune modifying for cancer, amiodarone, methotrexate, tobacco. Do they have BILD or DIP? I'll leave you to look those up. They both have specific CT patterns of injury. Do they have any connective tissue signs or symptoms? Scleroderma, polymyositis, rheumatoid arthritis, lupus. All of my patients think it's odd that I'm a lung doctor. When I first meet them, I always examine their hands and their face to see if they have evidence of scleroderma or polymyositis, dermatomyositis, or rheumatoid arthritis. Then, when I look at the imaging, I try to see if there's any other diseases that could be affecting the parenchyma of the lung, such as pulmonary Langerhans cell histiocytosis, which causes those shaped nodules and abnormal cysts in the upper and mid lung zones, LAM, diffuse cysts throughout the lungs, PAP, patchy, cravey paving. Then I think of granulomatous diseases. Do they have air trapping or ground glass and exposures suggestive of hypersensitivity pneumonitis? Do they have nodules and adenopathy that make 90% of the time you'll go through those 6 boxes and you'll say no, and then you'll get to the idiopathic, and then you'll have to figure out if they have IPF, NSIP, which of course most commonly product component, cryptogenic organizing pneumonia, or acute, which is usually ruled out on presentation. So I just wanted to start with that, so that when you see someone with interstitial lung disease, you always say, start from the beginning. It's a very good place to start. But you will arrive at most of the time, because IPF is the most common symptomatic interstitial lung disease. The most common interstitial lung disease is actually sarcoidosis, but fortunately, most of those patients are asymptomatic. Incidence varies 7 to 40 per 100,000. It increases markedly with age of 60. When you specialize in idiopathic pulmonary fibrosis, you always ask is, why are all my patients so old? It's because idiopathic pulmonary fibrosis is probably caused by many things, but we're learning, especially with telomere dysfunction and telomere size reduction, that it's a decrease in lung healing lung ages. So you lose telomeres, you lose stem cells, and you're not able to heal lung that normally is damaged with everyday life. And I'm not advocating any stem cell therapy. Every patient asks me, can I go get stem cell therapy? And I say, I would love to give it to you, but nothing, absolutely nothing has been proven. But I do think it is a disease of aging and probably abnormal stem cell repopulation. It's fatal, short-term progression, predictable, median survival is 3.5 years. So clinical criteria, again, it's a disease of older folks, so they should be above the age of 50. They shouldn't have any exposures or connective tissue diseases that would another diagnosis. and they should have a negative ANA and a negative extractable antigens. Inconsistent, which makes me scratch my head and makes me think of NSIP or hypersensitivity or sarcoid, most commonly in this part of the world, is age less than 50. They almost always need a surgical lung biopsy. Tobacco, pneumoconiosis, agents that cause hypersensitivity, and then the RA diagnosis by the American College of Rheumatology. That doesn't mean it's just a low positive rheumatoid factor. It means they may have a rheumatoid factor and significant joint dysfunction. Those are the things that make me wary of calling it IPF. And CT is our friend. Again, when we look at CTs, if we look at the edges of the lung, subpleural reticular, means net-like. So you've got this fibrotic net at the edges of the lung that's patchy, because you also see normal lung right next to it. And as you go deeper or lower in the lung zones, you can see that it gets more and more. So it's a basal peripheral predilection that's patchy, reticular, and you usually, to make the diagnosis, we used to say you have honeycomb lung change, which is still a very good indicator it's there. But we've also learned that traction bronchiectasis can be a good sign of IPF or certainly fibrotic lung disease. What is traction bronchiectasis? Well, IPF is not really the lung filling up with scar. People think, oh, it's up, but that's not the case. It's actually normal lung, normal alveoli that are collapsing and turning into scar. So it's actually not an addition of fibrosis to the lung. It's normal alveoli disappearing, turning into fibrosis, which makes the lung smaller on PFTs. You get reduction, restrictive lung disease, and pulls apart the bronchioles. And when they're dilated, we call them ectatic. So traction bronchiectasis is when the lung tissue is disappeared, turns into scar, and pulls those bronchioles open and makes them ectatic. And that's a good marker of fibrotic lung disease or idiopathic pulmonary fibrosis. Right, clinical reconciliation. If you have UIP, those four things: bibasilar subpleural reticulation that is without ground glass and significant ground glass, and honeycomb cystic change, that's IPF. Don't bother getting a biopsy. If one of those is missing, it's usually the honeycomb cystic change. But if bronchiectasis, I put that into the likely IPF area. If two of those four characteristics are missing, meaning they have more ground glass, they have more trapping. And what I mean by more is there's more ground glass of areas or air trapping than there is a reticular change. I call that unclassifiable, and that usually needs some type of further investigation. So diagnosis, again, the likely IPF diagnosis is something we see a lot, obviates a lot of surgical lung biopsies, because most patients are missing honeycomb cysts, but if they have traction bronchiectasis, if they have any signs or symptoms of connective tissue disease, if they're over 50, and if they don't have any other exposures to cause fibrotic lung disease, I treat that as IPF. That usually falls into the category of chronic HP or sarcoidosis or NSIP. I try to get a surgical lung biopsy, or more recently a cryo biopsy. At Cleveland, we are now able to do cryo biopsies, which is basically through a bronchoscopy, you stick a cold probe in which freezes a large area of tissue, and then you pull that tissue out. The risk of bleeding and pneumothorax, but since we do it usually in the central areas of the lungs, we avoid the pneumothorax. Now, IPF is a disease of the peripheral of the lung. So if you're really, I wouldn't recommend a cryo biopsy. But if you're concerned about HP or NSIP, which is more in the center of the lung, I then very often think of a biopsy, because that goes to where the money is. Treatment, I won't go into too much. But if I don't think it's IPF or UIP, I then of immunosuppressive agents. And if they progress, think of rituximab for HP. So diagnosis and treatment options. Nintedanib or pirfenidone, I'll show you some data on both of those and why. Basically, I think they're pretty much equivalent. I don't think one's better than the other. I switch based on side effect profiles. There'll be a question out there of, do I ever use both? Sometimes if a patient is tolerating one antifibrotic well and the progressing, I will add the second antifibrotic. We don't have any data on that, but we'll see they have different mechanisms of it, and I think maybe that will help the patient. So what course can unfortunately, it's impossible to predict. I've had patients diagnosed with IPF and rapidly progressed to death within that year. I've had people who live 8-9 years with IPF, and such that I doubt my diagnosis. But within 1 year, most patients who are mild to moderate, 10% will have a risk of dying, 40% will be unchanged, and 50% will worsen. And these numbers worsen with advanced disease or age. So it's difficult to say, oh, if you get worse, I will start fibrotic, because they're getting worse, maybe declining to death. Once I make the diagnosis, I then think of antifibrotics. I don't wait for them to progress, because it's not predictable and not linear. And there was actually a study in 2014 looking at this, and what they found at the University of Michigan, they wanted to look at is, okay, let's follow your pulmonary function tests for a year and see what happens. See if your pulmonary function tests get worse next year. Does that mean they're going to decline the next year also? Or if your PFTs stay stable the first year, does that mean they're to stay stable the second year? And what they found was that there was no predictability. So if you're stable 1 year, that does not mean you're going to be stable the next. So if I start someone on an antifibrotic and they're stable, I don't say, maybe you don't need it, let's stop it. No, because I don't know what's going to happen. Again, it's IPF, it's very hard to make predictions, especially about the future. IPF treatments, you can see we've tried a lot in the past. The only that are pirfenidone and nintedanib. This is just to show you the old Panther trial, which was prednisone and azathioprine with N-acetylcysteine added or taken away. And you can see the prednisone and azathioprine actually made people worse. They had a higher probability of death or disease progression. When we looked at acetylcysteine by itself, it had no benefit at all. So acetylcysteine and prednisone azathioprine have no role in IPF. Be gentle with the lung. What that means, very interesting study of a person who had, you can see on panel A, very mild peripheral fibrotic changes that are very consistent with early usual interstitial pneumonitis or IPF. Underwent a procedure where they had collapse of the right lung section for a nodule, and they had full ventilation to, and that positive pressure led to severe damage to. Basically, we caused with our positive pressure ventilation an acute exacerbation of IPF. And you look at the other side, that was collapsed for the surgery, you can see that there's very little damage. So the lung that wasn't ventilated with positive pressure did fine. So this is why the lung. If someone that I know has IPF and they need a surgery, the surgeons and try to have them do it under regional or local anesthetics with them, the patient's spontaneous breathing, basically pressure ventilation, because positive pressure ventilation leads to increased risk of exacerbation. And I've seen this and it's horrible. What about treatment of reflux disease? Published in 2013, basically looking at all of the failed trials for IPF that we had in the first 10 years of this century. And they grouped them all together and they said, how did the people who did PIs do compared to those that weren't? And what they found The ones that were on PPI had a little bit of a slower decline in lung function than those who were not on it, is shown by the red line. What it means is that if I have someone who has symptoms, any symptoms of reflux disease, I will put them on a proton pump inhibitor. There's basically no side effects. If they don't have any symptoms, I will talk to them about it and say, look, I think you should be on this. So I do use PPIs liberally. I tell them they're not, it's not going to make their lungs better. It's not going to keep them from getting worse. It may allow them to get worse at a little bit of a lower rate, a little bit slower. Again, and this shows that when they looked at the study with a PPI, it led to a reduction in an acute exacerbation, which kind of makes sense. If you had a little micro aspiration of acid, you're going to lung. In IPF, what did I say it is likely caused by? An inability to heal your lung. So boom, there you go. You've got injured lung that's going to not heal, get an exacerbation if you have a micro aspiration of acid. Pulmonary rehab, what this shows is that the pulmonary rehab in the left panel, distance increases a little bit, and in the right panel, your 4 time decrease. I like the 4 meter walk time, and it's clinical. So it's how quickly can you move 4 meters? So how quickly can you move around your house? That really goes to quality of life. And the shorter time, the higher quality of life you have. So you can see that pulmonary rehab, folks, and it maintains at 6 months. So I try to do some form of pulmonary rehab. If they can't do pulmonary rehab, I then try to have them do walking consistently at home. Let's talk about pirfenidone. So it's a kinase inhibitor, which basically goes in and decreases cell signaling through the MAP kinase pathway. You don't really need to understand that, except it does a lot of things to the cell. Basically, it reduces most of the activity within the cell. It almost like slows it down a little bit, everything. And you can see all these good things that it does to reduce fibrosis. And when you look in people, you can see that progression-free survival improved with pirfenidone. So if you took pirfenidone, you have a likelihood to be alive and to not get worse. Change in FVC, you can see by week 52, the placebo group lost about 400 milliliters on average, where the pirfenidone group had lost about 200. So it slows down your lung decline by about half. And it also reduced your respiratory-related hospital thing, because the last thing you want is these people to be in the hospital. Nintedanib is a tyrosine kinase inhibitor, so it also slows down cellular function, and it also does a lot of good things that you would think about to reduce fibrosis. Again, we think this may work independently of pirfenidone, but we've never looked at using them together. And you can see with nintedanib for IPF, they looked at 52 weeks in a little bit of a milder group. They on placebo lost 200 mLs, where the treated group lost 70 mL, something like that. So again, decreased lung decline about half. When you compare them, again, they both have 50% of the lung decline. I see them as efficacy. And the change in lung decline was probably because that people were less impaired than the pirfenidone group. And as I showed you before, the more impaired you are, the more likely you are to have a decrease. One of the other things that the nintedanib trials looked at was that fibrosis is bad in IPF. But what about fibrosis without IPF? What about fibrotic disease with connective tissue disease, fibrotic and SIP? What about hypersensitivity pneumonitis, which unfortunately in this part of the world, almost all the HP that we see is fibrotic HP. What they looked at is when you looked at UIP fibrotic pattern versus fibrotic patterns, and this was mostly HP or fibrotic and SIP, they all did poorly. They all got worse in the placebo group. So basically all fibrotic, whether it's UIP or HP. And this was a change. The study came out, we used to say, Well, you have fibrotic HP or fibrotic SIP. That's not so bad. At least it's not fibrosis of IPF. Well, it is kind of bad, and it does get worse. And what this trial looked at was, it was a very looked at nintedanib in people who had a UIP-like fibrosis versus nintedanib in fibrosis without UIP, and they had to be getting worse. So you had to have more than 10% of your lung be fibrotic, and you had to be getting worse over the last year. And they called this progressive pulmonary fibrosis, PPF. And what they showed was that if you had PPF in the absence of UIP when given pirfenidone, you had benefit. Again, the people treatment lost about 150 to 180 mLs. The people on lost 50 to 80 mLs. So it reduced the line in non-UIP fibrosis. For the last 2 years, we've really begun to talk about, instead of just P pattern of injury or IPF, we talk about progressive pulmonary fibrosis, because we know that's not going to be good. How I use them? Basically, I use pirfenidone and nintedanib interchangeably on the insurance. Some people, pirfenidone, if you don't have insurance and can't get it, some people can get it at very low cost in India, which is great. I use that a lot. If they have side effects such as rash or bloating with pirfenidone, I switch to nintedanib. If they have diarrhea on nintedanib, I switch to pirfenidone. And I do other if there's progression and if there's absolutely no intolerance. If someone is highly intolerant to these medicines, I do not use them because they're not an absolute cure. A little bit of good news. This was a study a few weeks ago, and I wonder if it's too good of news. So this is a preferential phosphodiesterase 4B inhibitor. Who knew it does? But Behringer seems to think it decreases, and they gave it to people for 12 weeks. Incredibly short time. The studies that I showed you before were basically 52 weeks for a year. They found that in 12 weeks, the placebo group decline of 80 mLs on average, where the control group of IPF folks were exactly the same. So is this too good to be true? It's data, but it could be revolutionary. So quickly going to go into a larger trial. You can see this was a relatively modest trial of starting off about 150 people in the groups. This is going to be eagerly enrolled. And this trial was actually done irregardless of whether they were already on pirfenidone or nintedanib. So some of the people were on no other agents, some were on pirfenidone, on nintedanib. They were randomized to be equal across the treatment and placebo group, as you should do. So that's what's even more amazing, is that this is in addition to those other agents. This could be fabulous. Everyone should be really excited. Now some not so bad news, not so good news. You may have heard of something called abnormalities. And what the heck is that? Basically, because of cardiac screening for calcium scores and nodule screening for cancer, we're doing a lot more chest CTs. And what we're finding are these little interstitial abnormalities. It's not enough to be IPF. It's not enough to call it because they're asymptomatic. It's an incidental finding that either central, subpleural and non-fibrotic is in B, or subpleural and fibrotic is in C. And we didn't, because we thought, this could be just a little bit of something there that it's not bothering the person now, and it's never going to bother them in the future. The problem is that when we watch these, the subpleural fibrotic usually progress, and in 5 to 7 years, not only do they have IPF or fibrotic diseases, they die. So that's the little bit of news. Is when I used to see these scans, I would say, it's probably nothing. You don't have a cough. You don't have any cough. You don't have any shortness of breath. Don't worry about it. But now about it, and I do get follow-up. I get baseline PFTs, of course, and then in 6 months get a follow-up CT and follow-up PFTs because I'm worried about them progressing. And so that's the end of my talk. So The diagnosis, we all know what UIP, IPF is, but now we know that likely IPF we can treat as IPF. We also now know that progressive pulmonary PF behaves like IPF and can benefit from treatment with antifibrotics. I showed you the study with nintedanib, which now has that indication. Pirfenidone has not studied it in that situation yet. However, there was a meta-analysis that looked at in patients with non-UIP fibrotic changes. It was an analysis of 2 small studies that did reach clinical significance for protection of the lungs. It was a meta-analysis of 2 small studies. The data isn't confirmed as a randomized controlled trial. So I do use nintedanib first because they have the better data. If they are intolerant of nintedanib, progressive pulmonary fibrosis, I will go to pirfenidone based on meta-analysis. Again, and I try to keep the lung, keep an eye out on that new agent. So thank you very much for attending. I'm sorry I couldn't be there. I am not in your hemisphere right now, unfortunately, and I'm actually on a plane right now. So I know it's going to be a great conference. So have a good day. Take care.
Okay, I'd like to thank our speaker for an excellent presentation.